Hi, my name is Dr. Kendra Saxvik. I'm a clinical pharmacy specialist. I'm a board-certified psychiatric pharmacist, and I specialize in mental health. Today we're going to be talking about some cultural considerations within integrated behavioral health care. So some learning objectives, we're going to discuss patient cultural considerations for mental health within primary care settings. We're also going to discuss staff culture considerations when developing an integrated practice. When we're talking about patient barriers to treatment, there's always many things to consider. When we start looking at these barriers, we also need to consider the reasons behind them and how do we address that. And often they're cultural in nature for a variety of reasons. Mental health treatment carries a significant stigma. Despite steps forward in recent years as a culture, there's still a significant stigma in many sections of the populations. These reasons vary by culture, but also by geographics. For example, the culture in LA is very different than the culture of rural small town Texas, and we're going to talk a little bit more about that later. The end result is that mental health diagnoses are often not recognized or under-recognized when they present to primary care, as they're not bringing them up due to these barriers, and so then no referral for treatment is made, which means that the patient is not getting an adequate treatment. When we're considering how we treat patients, we need to take into account that they may have personal barriers preventing them from engaging in care, but more specifically in specialty care for mental health. So let's start by looking at the geographical considerations I just mentioned. Firstly, let's consider rural areas. Those in rural areas may avoid seeking care due to perceived lack of privacy or anonymity. In small towns or rural areas, everyone knows everyone, and everyone knows what everyone else is doing. This can make it difficult to open up about things that carry a stigma, such as mental health. They worry that what they discuss will not stay confidential or will be overheard, leading to rumors and having a negative connotation. And this is not just within doctors' offices, but being seen walking in and out of offices or overhearing a medication name at the pharmacy, all of those type of interactions. Further, it's difficult to attract providers to rural areas. This means that the access to care can be very low for patients, and they may have to travel a great distance to get to their appointment. This means time off work, as well as the expense of getting there. But an added layer of complexity to this can be the perception of these providers as outsiders if they're from other areas, which can instill some distrust that must be overcome within that therapeutic relationship in order to be effective. Besides the difference in our rural communities, there's also a significant difference between regions of the country, as I hinted earlier. And to look at this, the CDC and SAMHSA collaborated to research this across the country through a survey. What's interesting about what they found is while they found distinct differences between states, there were no clear patterns when we started looking at a more regional level. They found that attitude towards mental health may be affected by the religious predominance of an area, as some religions have stricter or more accepting views of mental health. Economic situation, as we know, lower socioeconomic status tends to correlate with more mental health issues, but also less access. And finally, access to care. In areas with more access, there tends to be more acceptance. And I've actually seen this having worked in a metropolitan area versus a rural area. It can be far more difficult to engage patients in these rural areas for the reasons I just talked about. I want to note that just because engagement may be low in these areas, this doesn't mean that there is not a need. And integrated care may be a good solution to improve the care in those areas. There will not be as much gossip going to the primary care clinic versus the psychiatrist's office, for example. And there are often more primary care clinics than specialists in rural areas, so there is also closer and easier access within that setting. And these are some things to think about when we start thinking about the benefits of integrated care. Another factor to consider, regardless of geographic location, is that different ethnicities have disparate views on mental health and its treatment. For example, minorities have been shown to be less likely to seek and engage in mental health care, and we're going to take a look at some studies showing why that might be in a moment. However, they've also been shown to be more likely to seek this treatment within the primary care setting. The reasons for this are likely linked to a long history of mistrust of the medical profession, as well as cultural stigma surrounding mental health. This stigma, in turn, further exacerbates this mistrust, which ultimately leads to less patients seeking care. There have been some studies looking at the underlying reasons behind some of these differences in ethnic responses and attitudes towards mental health. I'm going to focus on one of these. Jimenez and colleagues specifically looked at this in their study, and they utilized a survey asking about cultural attitudes towards mental health and its treatment within a larger study called the PRISM-E study. They looked at these attitudes because in turn, those attitudes and belief influence how they choose to get treatment and where they prefer to get treatment. Interestingly, there was a wide difference in what was believed to be the cause of mental health issues. Those of non-Latino white ethnicity tended to believe that medical illnesses, chemical imbalance, and loss caused mental illness, while African Americans tended to believe that stress was the primary cause as well as loss. Asian Americans tended to believe that family issues, medical illness, and cultural differences caused mental illness. And finally, while Latino Americans also tended to believe that medical illness and loss caused mental illness, they also tended to believe that family issues, moving or relocation, and the spirit or psyche also caused mental illness. I want to note that non-Latino whites had significantly less percentage of people reporting these beliefs than across any of the other cultures. When asked how they would prefer to seek treatment in regards to mental health concerns, we see that each ethnicity tends to prefer different options. Latinos and non-Latino whites both preferred counseling or medications, but Latinos preferred to seek that treatment from psychologists, not psychiatrists, possibly indicating preference for those medications to come from non-specialty care. Asian Americans indicated that they did not have a preference, but they also indicated they did not wish to engage in treatment with a specific type of person, which in this study indicated mostly that they would not engage in care at all. And African Americans were most likely to want to engage in spiritual advice as a treatment preference and from family members versus through the healthcare system. I also want to note that across all ethnicities, regardless of their beliefs on the cause of mental illness or their treatment modality preferences, all ethnicities indicated that they were much more likely to talk to the medical doctor than to a psychiatrist, with the noted exception of Asian Americans, but again, they were not likely to engage with anyone. Knowing that there is a strong preference to seek treatment in medical versus behavioral setting across cultures, integrated care may be a great solution to increase engagement in treatment and improve patient care. This is a setting that they clearly have a preference for, and meeting the patient at their level of comfort is a great way to begin to assess and move past the barriers, including those that arise out of their ethnic identity and background. Kind of moving on from the ethnicity, there's actually a lot of cultures that value masculinity and often place these values onto the males within the culture. And this is true across multiple ethnicities and cultural background. And to kind of provide a framework for how this looks, military training actually really well exemplifies what this looks like. They encourage conformity to hyper-masculine ideals, which are found again across multiple cultures. In particular, emotional control is highly valued. However, this means that emotions are viewed as weak or negative, and which in turn creates avoidant patterns of behavior, rigid emotional control to avoid being viewed as weak, and ultimately an unwillingness to experience emotion. Working with veterans, this is a barrier we come across a lot. Emotions are viewed as non-masculine, and therefore admitting that you are struggling with them or other issues is viewed as weakness, and for this reason they are less likely to seek care. I do want to note that this effect is mitigated some with age, however, and older men are more likely to seek treatment. Unfortunately, that means that they have been dealing with some of these issues, mental health issues, untreated for a very long time by the time that they're seeking treatment. Again, there's a stigma with mental health, which is even more pronounced when a patient holds these hypermasculine ideals. They may be more willing to discuss this in the primary care setting, as they do not view it as mental health, but rather a medical setting. And once again, integrated care is a great way to engage these patients in treatment. Now that we've kind of considered some of the cultural considerations of our patients, now I want to talk about staff cultural considerations when we move towards an integrated care model. So mental health and primary care providers, per the World Health Organization, 1/4 of primary care visits are for mental health. So 25% of all visits across the nation are for mental health within the primary care setting. There's a variety of research that shows about 50% of patients with mental health issues seek care from primary care versus mental health. And again, this is mainly due to stigma and the cultural reasons that we've already talked about. What does this mean? This means that primary care providers are spending a significant amount of time treating mental health. And studies have shown that many patients go unrecognized or untreated. When you have a primary care appointment, you have a very limited amount of time to cover a lot of things. And as medical providers and specialists in medical needs, those often tend to get prioritized. Whereas the mental health needs, since it's not their specialty and not their primary concern at that visit, tends to get minimized or not treated. there's also research out there that shows that patients with mental health disorders are more likely to have unmet expectations for their medical care. What this ultimately means is that they have unrealistic expectations for what can be done, and this leads primary care providers to find them more frustrating patients to deal with and not wanting to see them as often, and having more job dissatisfaction when they have to deal with these type of patients. So again, looking at the literature, there's lots of literature out there, but I want to focus on a study done by Upshur and Weinreb. In 2008, they did a survey of PCPs on attitudes towards depression treatment. And what they did was that they gave this survey before implementing a more integrated model and after a more integrated model. Before they integrated the model, the attitude of the primary care providers was that depression was overemphasized as a problem. And they also had a viewpoint that treating it is very time consuming. When they were thinking about their skill level in treating it, most felt that they could effectively treat it with medication, but not with counseling. And so this, which goes back to a lot of their comfort level. Their comfort level with medications is much higher than with counseling, and they have seen the effects of medication, but not counseling. What's interesting is that only 56% felt certain they could recognize depression if a patient was presenting with it, and only 13% felt very certain that they could recognize it. The survey also asked questions regarding behavior, and what this meant was how they were likely to treat the patient. They were mostly unlikely to refer to specialty care or to tell the patient to call their insurance to locate a specialist, and they were unlikely to provide any educational materials regarding depression. The last thing the survey looked at was provider satisfaction, and in general, most providers felt that they were constrained by time within their appointment and that they were also not fairly compensated for that treatment. Again, what this led to is less treatment of these issues. So they provided some education and initiation of a collaboration with the case manager within the primary care setting. This was done across a couple of different sites. And then after a couple of years, they reissued the survey. And it was really interesting to note some of the changes in the perceptions of the primary care providers. When we looked at attitude, remember before the survey, they felt that depression was overemphasized as a problem. After having an integrated model, they disagreed that it was overemphasized as a problem, meaning that they did not feel that it was an overemphasized. And again, beforehand, they thought that treatment was very time consuming. After integrating a model, they felt that it was not time consuming. When they looked at their skill level, prior to the integrated model, most primary care providers felt that they could effectively treat depression with medication, but not with counseling. Afterwards, they felt that both were effective, and they felt more comfortable in doing that. There was also an increase in the certainty in which they could recognize depression, though it wasn't statistically significant. And when we look at their behavior, again, prior to the collaboration, they were not likely to refer. Afterwards, they were likely or very likely to refer to specialty care or to tell their patient to call their insurance to locate an available provider. They're also much more likely to provide educational materials to patients when they presented within their clinic. Finally, looking at staff satisfaction, overall, they felt less constrained by time after collaboration and still generally felt that they were not fairly compensated for this treatment. And now I want to talk a little bit about my own personal experience. I've worked in several settings. I currently work with severely mentally ill. I have worked with this within primary care. I've worked with the severely mentally ill with primary care integrated into the psychiatry clinic. I have also worked within primary care with mental health integrated into the primary care clinic. I have also worked in settings with separated service. I have worked in rural areas. I have worked in some more metropolitan areas. And what I've learned in all of these different settings is that patients get better care within the integrated models. When I say the severely mentally ill, these were patients with things like schizophrenia, bipolar, and so the primary care providers, when they were integrated into that, became much more comfortable handling patients with these type of severely mentally ill and psychotic disorders. Vice versa, when we integrated mental health into the primary care setting, primary care providers became much more comfortable asking the questions because they knew that they had somebody to be able to refer them to, somebody that could help them with the care of that patient, whether that be counseling or medications. When I worked with separated services, there was a disconnect. And while the primary care provider might feel that they needed, for example, a medication and they may be comfortable starting one, they weren't really comfortable asking the follow-up questions. And so they may, because of that, they may not be likely to further dig in and realize that that medication, for example, might not be working as well. And on the flip side, when we separate mental health from primary care, there can be a level of frustration with the mental health providers because they feel that their patients' primary care needs aren't getting met, which in turn affects their mental health. If their diabetes is uncontrolled and they're ending up in the hospital, that can be very depressing, for example. I have been in settings where we have implemented the primary care and behavioral health integration. It does require a culture shift of the entire healthcare organization. We have been separate for a long time, and so anytime you implement change, you also have to think about the culture of your staff, as well as the patient expectation. Again, I have worked primarily with the veteran population, and they have been very responsive to having mental health available to them when they come to their primary care appointment. They are less responsive, at least initially, in getting to the specialty care. They don't want to believe that they're that bad as weakness. Initially, the primary care providers kind of glossed over a little bit the primary care mental health providers because they didn't really see how they could fit in. But as they began to really start to utilize them and to see that their patient outcomes were better and that the patients were accepting of this model, more and more referrals came, and now we've had to massively expand to be able to handle the workload. And it also takes that workload off the primary care provider, so now they can focus on the medical issues. All in all, it has been a big success with patients being satisfied, the providers being satisfied, and in the end, that improves patient outcomes. So in conclusion, we've talked a little bit about the cultural considerations of both the patients and the providers. There are lots of cultural considerations when you're treating the mental health from the patient standpoint, and having mental health embedded within primary care offers the opportunity to treat these underserved cultures. On the flip side, we also have to take into account medical staff consideration, and the way that we can improve patient care requires education and seeing value in these services. I'd like to thank everyone for your time, and we'll have some further discussion.
Hi everyone, thank you so much for being here today. Today we're going to be discussing cultural considerations within the Integrated Behavioral Healthcare Foundation. And so before we get started, what I wanted to do was just kind of go around the room and have each of you introduce yourselves and sort of explain a little bit about what it is that you do.
Sure. I'm Dr. Kendra Saxvik. I'm a clinical pharmacy specialist. I specialize in mental health, and I currently work in the specialty mental health setting within the VA here in Corpus Christi.
And I'm Pam Green. I am an assistant professor here at the College of Nursing and Health Sciences, Texas A&M. Been here for about 3 years, and prior to that, I was working in the clinical setting for psych mental health for really lots of different settings over the last 39 years.
I'm Kristen Hines. I'm an LPC, and I work in primary care mental health integration with the VA outpatient clinic here in Corpus.
Thank you all for being here today. So in starting off and kind of looking at this idea of cultural considerations, it's applicable no matter where you are. And so one of the things that I want to start with is just kind of talking a little bit about cultural considerations with reference to the patient, given each of your individual disciplines. So.
Yeah, well, in graduate school and going forward, we've always been taught that each interaction is a cross-cultural interaction. Everything about you is different from everything about this other person. You don't know anything about their background or how they grew up. So making sure to be really sensitive about that and and asking what's important to them, and what makes them who they are, and making sure that you're attending to that too when you're meeting with them.
And for me, it's always been about patient-centered care, and it's kind of saying the same thing but a different way. That notion of really understanding them as an individual to get at whatever their value system is, their culture. But we also know that we're not, in general, that great in some different groups at asking the right questions sometimes, or being sensitive to specific needs, like in the LGBTQ community, for instance. We're just now better understanding some of the health concerns that are unique to that whole population. So there's always room for patient-centered care, but we always can expand our thinking better or more in terms of how to really appreciate and understand some specialty healthcare needs.
I agree, and I think when we think about cultural considerations of the patient, we need to think about them on multiple levels. I've worked in cities, I have worked in rural, I have worked in South Texas, I have worked in the North, I have worked in California, I have been across the country, and each is a little bit different as far as the layers. You know, we have our own cultural identity that is ties them to our ethnicity, but we also have to our geographic location. Having worked in rural versus city, there is a big difference in the culture and how they view not only mental health but healthcare in general.
Sure.
And that varies by location and how rural they are as well. Because, you know, I grew up in South Dakota, and so to me, a large city is 70,000 people. Here in Texas, that's still considered rural. And so as a practitioner, whenever you come into a new area or a new situation, knowing kind of how that culture around you is and how it compares to yours and how you can adjust the way your cultural upbringing can help you relate to other patients. Because, you know, here in South Texas, again, we have some of our communities are quite rural. Some of them aren't. We do have a large Hispanic population, but we also have a Southern population. You know, thinking about all of those different things and what does that mean for the patient. And when you think about all those things, then you go back to, okay, the person in front of me, how do they conform to each of those social things? The only way you can get to that is by talking to them.
Mm-hmm.
And included in those layers, when you're talking their faith beliefs, for some
Yes.
people that impacts
Absolutely.
a lot of how they perceive healthcare. And so in some areas of the country, particularly rural areas, but not limited, there's something called parish nurses, and they serve congregations of people. And when I say they serve them, they're usually not advanced practice nurses, but they are there to do like a lot of patient education. So they may do a brown bag lunch on hypertension or on self-care or just general diet nutrition to help kind of bridge some of those gaps in those areas where there really aren't ready access to healthcare providers unless you really drive an hour and a half to get there, and so you're not likely to go very often. So doing some health promotion and prevention can be done in different ways.
Yeah, and specifically when looking at mental health, I think too, now that you mentioned that, people might go to their spiritual guidance person, whoever that point of contact is, a priest, minister, whoever it is, for any sort of life guidance that they need. And so it's important for, at least for me, coming from my perspective as a counselor, thinking, okay, they might be getting something else from someone else too, and making sure to ask and have that awareness of what's going on.
And now, with the use of technology embedded in it, it was at my grandchild's house, and he had an unusual reaction to a bite, and I just watched as they took a picture with their phone, sent it to their health systems, and within 10 minutes had an answer of what they needed to do next. So that's generational. I'm not likely to do that, but I saw how beneficial that was. It saved them a trip in large city traffic on a Saturday morning. So we think about generational access to care too. So when you talked about layers, it just resonated at all the different kinds of things, as well as even gender kinds of issues too. And who, females we know are more likely to seek care than males, but not always. I mean, we don't want to stereotype either. That's the other side of this, is not, we have to be sensitive to the cultural issues without stereotyping, and it's back
Yes.
to that patient-centered care, that person in front of you, the communication.
Absolutely. And so I'm curious, kind of building on that, Dr. Green. So we talked a little bit about sort of the approach of cultural considerations with patients, but that sounds like that's a lot of responsibility on the part of all of the staff as well. So can we talk a little bit about sort of cultural considerations with the staff members in regard to integrated healthcare?
I think you first have to think about when you're as a practitioner, not only your patient's cultures but yours, and how does that affect the way that you provide care. But more than that, we also have to look at it from the system level. How is the culture within the staff of your clinic? How do they view integrated care or not view it? If it's a new model, and how do we relate to each other both interprofessionally, but also as providers? How do we relate to the patients, and how do we let other providers know how do we relate to the patients? If that makes sense.
And there's historically, and hopefully that's being kind of eroding, but there's been kind of a hierarchy based on specialty. Certain specialty areas in healthcare overall have a higher status, if you will, than others. I, years ago was confronted by a nurse from ICU saying, basically all you do is sit and play cards with patients. Right. And it's that idea of, oh, well, mental health was kind of low on the totem pole, right there with maybe dermatology. Not that those things should be discounted or discredited or devalued, but some of it has to do with our economic system and that sort of thing. But we really have to help others understand really the scope of practice and what we're doing, and how mental health is impacted by the physical health and the whole allostatic load principles and those kind of things. But attitudes within healthcare providers, though, is very interesting.
It really is, and I've worked in several different settings. I've worked in places where they're completely separate. I have worked in a collaborative practice model where mental health was embedded within primary care, and I've worked in the reverse, where it's a severely mentally ill population. So it's a psychiatry clinic where they have then integrated primary care. And so seeing it's been interesting in my career to see how that has kind of spanned across. And ultimately, once it's successfully integrated, everyone has more job satisfaction. The patients have better outcomes. They're in the hospital less. They're in the doctor's office less because they're doing better. But how to get there is addressing some of those cultural differences between professions.
Yeah. So you're not only kind of looking at this from an ethnic perspective when you're taking in cultural considerations, but you're also looking at the culture and the climate of the staff that you're working with.
Exactly.
And their backgrounds, not only professionally, but again, it's like you may have language differences because we're working with colleagues that are coming from other countries or other parts of the countries, and so different things mean different things.
Right.
And we have to be clear.
Yes, we do have to be clear, and our staff culture, as we relate to each other, but our own personal beliefs. We work here in this area where and particularly where I work, there's a large Hispanic population, and there tends to be a lot of machismo in that culture. But then add on top of that, I work with veterans, and there is a huge machismo component to that, and there's a lot of drilling down on that within that subculture, is that emotions can be viewed as weaknesses, and so you're taught to kind of tamp that down. Further within veteran communities is if you start to express some of those problems, you might not be able to stand next to your brother and go to the front lines. You may not be able to have some of those same interactions. And so that adds a whole big level of component to the patient level, but you still have those attitudes and those beliefs within the practitioner as well. And so if you have practitioners that are of that type of cultural mindset, they may minimize mental health. And that means that they may do that within their patient interactions, but also within their referrals and things like that, and not recognizing it as a piece of the whole.
Absolutely. And so with that being said, given sort of each of your disciplines, what are ways to mitigate that in order to reduce that stigma and really kind of increase the quality of care that the patients are receiving?
I really think that the integrated model within primary care has been the place where I have seen the most difference that makes. As mental health providers, being available, being able to educate in an informed, concise way to the providers that this is how I can help you with your practice. And having some of those positive interactions starts to change some of the mentality in that they start to have less minimizing within their patient interactions. So kind of playing up that, well, all of this kind of goes together. You know, the fact that you're having a lack of motivation ties into why you're not taking your diabetes meds. I have somebody on my team that can help with that and kind of get to the bottom of that. And presenting it in that manner is as opposed to, well, I think you're depressed, so I'm going to send you over here. And the tone can be more dismissive. Whereas if you have more of the integrated model that's immediate access and face-to-face with that primary care provider, starts to break down some of those stigmas and those barriers. Then on the patient side, having it right there. You know, I don't have to go to a separate building. I don't have to go, at least not at first. You know, so it's kind of like, well, my doctor says I need to and I'm here today and it's right here. Maybe I'll just go see what it's about.
Yeah, I think the most important thing we can do is work to break down the stigma. Through other providers, through patients, just the general public. You know, we talk a lot about having these conversations at work with patients and other providers, but having these conversations with your family members too about like, okay, mental health doesn't mean you are hospitalized and you don't have any ability to do anything. You know, there are varying levels of mental health treatment. A lot of even my own family are like, so what do counselors do exactly? So, you know, educating other people so then they can continue to educate, because, you know, just one drop in the bucket will start the ripple.
Certainly. And one of the things that I think about in listening to both of your perspectives is, especially given sort of our climate here in South Texas, there's a large Hispanic population and there is sort of that stigma associated with healthcare and mental health, and that's the same for many other ethnicities as well. I'm Italian, same kind of thing. They just they don't see mental health, they don't understand. I think it's sometimes a lack of understanding, especially when you're looking at generations. And so having something like integrated behavioral health all in one place when you're looking at cultural considerations can be really beneficial, because if someone's going in because they have a broken leg, but while they're there, they can also receive input or perspective from other disciplines, then they're not going and seeking mental health, which is something that may not be supported by their culture. So is that something that you guys find?
Oh, yes. Oh, yes. When I worked in primary care mental health, I saw that quite a bit, that they were willing to see me when I was within that clinic. And I made the transition from primary care over to specialty care. And I had a few patients that were like, well, I wouldn't have come seen you in the other building. Like, I wouldn't have done that. But now that I know you, now that I've seen kind of what some of these benefits are, now I would probably be willing to go do that. Absolutely. And so it was rewarding to see that as a practitioner, that you kind of help change some of the patient's mind. And the more that you have that service available, patients talk to each other. You know, the father goes in and has this experience. He's going to tell his wife about it. He's going to tell their son about it, and who maybe the son is struggling with something, and knowing that type of service available and that it's okay to seek starts to change that on a cultural level.
Yeah, having that integrated model and being able to just jump right in where the PCP leaves off. So there's no gap. They're not waiting. They don't have to wait for weeks for a referral. They don't have to go to another building. They don't have to worry about who they're going to see. You know, being able to just introduce myself and give an idea of what services are available, and kind of touch a little bit on current symptoms, so that way they can feel it out a little bit, see if it's something that they can be open to. It doesn't feel quite so threatening, I think.
Certainly. And it sounds like cultural considerations can also really be mitigated or really addressed when you're also providing local resources and things within the environment that your clinic is based, or the area that you are. So I'm wondering what you guys think about local resources and how that benefits.
Well, in the last 3 years, the NAMI organization, the National Alliance for the Mentally Ill, has really formed here in the Coastal Bend, and they've been very strong. They've been able to secure grants for programs. So they now offer a program called Family to Family. They offer peer support and peer training so that once a week, I think they have a group for people who are struggling with mental illness or in recovery, can talk to other people who are further along in recovery but have a certain level of training as a layperson, so they know kind of where to draw the lines. They're not trying to substitute as therapists. The family to family support is wonderful because it really does help families feel less isolated and understand much better what's going on with their loved one. And then there's the American Foundation for Suicide Prevention. The local group here is maybe a year and a half old, and they've been amazing to me in that they sponsor a large walk, and they've had over 1,000 people at the last one, which was just this past fall. And what happens there is people are giving their testimonies kind of impromptu. So you see somebody that looks like you, and they're talking about the loss of their son, their daughter, their husband, their wife, their father. I was amazed at a 13-year-old boy who was talking to me about the death of his father, and it really helps break down the stigma because they're coming together for a common cause, and there's no secret. This is about people who have lost others to suicide, and so I think to have that here in our community is wonderful, and it's not just a once-a-year walk. They too reach out to each other in small groups. And then there's another monthly group that meets that is for people who have lost somebody through suicide. These are groups that are free, and people can go once or they can go every time they're offered, that sort of thing. So it's another way through a grassroots kind of movement to help people connect and to decrease the stigma. And it's not a substitute for the treatment in integrated care by any means, but it is an important support outside of what can be offered sometimes by health professionals.
I think it's a great adjunct in addition to the treatment that
Yeah.
you can get through the integrated care model.
Absolutely. So it sounds like there's a multitude of ways to kind of take these cultural perspectives into consideration. We've discussed it from a staff perspective, we've discussed it from a patient-centered viewpoint, and also from a community-based standpoint as well. So I want to thank you guys for providing us with your knowledge and discussing this topic. Is there anything anyone would like to add?
When you mentioned the community, I will add that there is another grassroots group that's the coalition that meets, and it's for the focus is on suicide prevention, and we do sponsor free educational programs for healthcare providers, not specific mental health, but that's generally the people who participate in these programs. But we also want it to be for primary care providers as well. And we've expanded the group now. We have the police department actively involved because they often are the first responders when a call goes out. So I think, again, it's in this way within this community of breaking down the barriers and being able to talk openly. And I just have to say our police department has done some phenomenal work, and as always, people would like to have more resources to expand it even further. So I'm optimistic here with the opportunities that are ahead of us all the way around.
That's great for our community.
Absolutely.
I think my last thought on kind of the integrative health model and culture is that the integrated model can go a long way towards making mental health treatment less scary. Not only from the patient's perspective, because it's kind of a way to gently ease them in, but from the provider and the primary care perspective. Our primary care providers provide 80 to 90% of antidepressant and anxiolytics, and being able to have some more backup to be able to kind of approach that can make it a lot less scary for them. And so in the end, the patient benefits, but so do the providers.
Absolutely. Well, thank you guys so much for being with us here today, and thank you for your input.